All right. So again, thank you everyone for joining us today. I'm very happy to introduce, for those of you who don't know him, Dr. Amir Azizian. Amir holds a master's degree in Community and Population Health Sciences from the Community Health and Epidemiology Department in the College of Medicine at the University of Saskatchewan. He also holds a Doctor of Medicine degree from Tehran University of Medical Sciences from his home in Tehran, Iran. He is currently working as a Learning Health Systems Specialist, collaborating with the Clinical Excellence Portfolio within the SHA. He's been doing that since December 2020. And he previously served as an Appropriateness of Care Specialist at a Saskatchewan Centre for Patient-Oriented Research, or SKIPPR researcher, with the Saskatchewan Health Quality Council from 2017 through 2020. And then prior to moving to Canada, he practiced as a family physician in primary care settings and public hospitals back in Iran. So thank you very much, Amir. I'm looking forward to hearing your talk today, and I'm hoping that everyone will enjoy getting a bit of a rundown on what learning health systems are, and then I'll take a couple minutes at the end just to kind of tie that into the antimicrobial stewardship piece and how these things are related. So thank you very much, Amir. Please take it away.
Thank you very much, Jason, for the introduction, and thank you everyone for your time and joining to this session. Appreciate that. So I'm going to share my screen and then having the chat over there. Hopefully I can see the chat. Please feel free to put your questions in the chat. If I can see the questions, and I'm going to monitor the chat periodically, but if I miss your questions, I'll look at the chat at the end and hopefully we can answer questions. So again, thank you everyone for your time. I appreciate it. This presentation is about an overview of learning health systems and some examples in action. As Dr. Vanstone mentioned, my name is Amir Azizian. I'm a specialist collaborating with the Stewardship and Clinical Appropriateness Department at the SHA and co-presenting with my colleague, Dr. Vanstone. I would like to acknowledge that we are gathering on Treaty 2, 4, 5, 6, 8, and 10 territory and the homeland of the Métis. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples. I pay my respects to the traditional caretakers of this land. Here are the SHA's vision, mission, values, and philosophy of care. Learning health system principles and learning health system core values support the SHA's values. In the coming slides, I will briefly explain how the learning health system principles and core values relate to the SHA's values and philosophy of care. In terms of the goals, at the end of the presentation, my hope is that you will know the definition of learning health systems and have a better understanding of their key components. I also hope that you will come to learn a bit more about the learning health system examples in action in Saskatchewan. So in 2013, the Institute of Medicine, now known as the National Academy of Medicine, published a report entitled Best Care at Lower Cost, The Path to Continuously Learning Healthcare in America. Here's an image from the report. It shows how with science, insights are generated but are often poorly managed. Then the science or research findings lead to evidence, but the evidence is often poorly used. And further, evidence leads to care, but it is often poorly captured. And that all adds up to the patient experience. Missed opportunities, waste, and harm happen as a result of poor management in science or research findings or evidence and care, and they then all to poor patient experience. In their report, the Institute of Medicine proposed learning health systems as a key strategy for improving value in healthcare. They defined a learning health system as where science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embedded in the delivery process. Patients and families are active participants in all elements, and new knowledge is captured as an integral byproduct of the delivery experience. The learning health system supports the implementation of best or leading practice and evidence in a more timely manner. The Institute for Better Health in Ontario provides a visual representation illustrating the transformation of the research paradigm. And I really like this visual because the diagram depicts a traditional separation between research and care delivery at the top, with these activities occurring in distinct entities. Research typically takes place in academic institutions, while care delivery happens in hospitals or clinical settings. As the research paradigm evolves, a knowledge translation and exchange model emerges in which those siloed organizations start communicating their respective experiences and realities and what they are or they were learning. In the evolution towards a learning health system, the focus shifts to the integration of applied research and evidence support. The intersection in the Venn diagram symbolizes the alignment of research questions with insights from care delivery realities. In addition to that, the operational decisions and strategic planning in care delivery is informed by research and evidence perspectives. So internal and external to the organizations or health systems, evidence influencing the decision-making processes in the care delivery. So the newness of the learning health system concept has led to doubts about the fundamental principles of the learning health system and has caused a certain ambiguity in defining its limits, making it challenging to distinguish it from other methods for enhancing healthcare and health outcomes. Questions such as, what is unique about this approach? Or isn't it the standard way to enhance anything? Or how else could you approach it? Are common questions in this field. So on the screen, you see a visual. This is from Dr. Charles Friedman, who describes the distinction starts with the idea of a learning or improvement cycle, and the claim that learning health systems enhance both individual and population health by combining discovery and implementation through iterative cycles as depicted in the figure. The cycle begins at 5 o'clock with the establishment of a multi-stakeholder learning community. And guided by the community, the cycle proceeds with collection of data to capture what is happening now, also called performance to data or P2D, analysis of this data to generate evidence of how improvement might be affected, also known as data to knowledge or D2K, and the integration of locally generated evidence with relevant evidence gathered by others, and intervention based on that evidence to result in improvement, also known as knowledge to performance or K2P. From here, the cycle repeats in a series of iterations over which data-driven improvement can occur. In Dr. Friedman and his colleagues' terminology, the learning or improvement cycle marries discovery with implementation. So what sets apart the learning health system cycles from traditional quality improvement, PDSA cycles, for example, the Plan, Do, Study, Act cycles, can be categorized in three distinct factors or buckets. The first factor is the initiation of learning cycles by forming a collaborative multi-stakeholder learning community dedicated to addressing the issue collectively from start to finish. This is very important when considering the continuous nature of learning cycles. Interrupted cycles occur when entirely different specialized professional groups within an organization execute each component of the cycle. A group specializing in performance to data or P2D might be focused exclusively on program evaluation or quality assessment. A group specializing in data to knowledge or Day2K might be focused on health sciences, health services research, and a group specializing in knowledge to performance or K2P might be exclusively focused on change implementation. So the members of each of these relatively homogeneous groups will have similar educational backgrounds and professional cultures, but the backgrounds and cultures of each group may differ greatly from each other. However, after a learning community forms into a cohesive group, that same group depicts the cycle through the sequence of discovery and implementation. So discovery phase is the performance to data and data to knowledge, and implementation is knowledge to performance, and back to discovery again as the cycle continues. So that's the first distinguishing factor. The second distinguishing factor is the embracing the initial uncertainty regarding how to address the problem, but conducting a thorough discovery phase before implementing any changes. Within the field of learning systems, embracing uncertainty is seen as a positive attribute, while rushing into certainty too early can risk one's chances of success. And then the third factor is establishing a socio-technical infrastructure that enables the support of multiple concurrent cycles, creating a comprehensive learning system. Without an infrastructure in place, a group of cycles remains just that. However, once there is a structure in place, a cluster of cycles transforms into functional learning system. Here, I'd like to expand a little bit on the concept of concurrent learning cycles in the learning health systems. In a learning health system, various cycles of learning, excuse me, or enhancement can simultaneously take place. The infrastructure of a learning health system, encompassing elements like policy, processes, technology, or people, offers services and has the capability to facilitate all concurrent cycles. This is because all cycles fundamentally follow a similar process, moving from performance to data, then from data to knowledge, and finally from knowledge to performance. The cross-cycle sharing of services allows for an essential economy of scale within the system, contributing to its sustainability. Another point I'd like to mention is the pace of these cycles, which varies based on the nature of the health problem or issue, with some progressing rapidly and others at a lower pace. As I will present in the examples, learning health system in general and learning cycles in particular can exist in different scales, from a local to provincial or even global scale. Here's a Canadian version of a learning health system framework for value creating learning health systems developed by Dr. Matthew Minier and his colleagues in 2019. This framework has been adapted to develop the SHA's learning health system conceptual model. Dr. Minier is a researcher from Quebec, specializing in mental health and addictions in primary care and patient-oriented research. In their work, learning health systems are dynamic health ecosystems and characterized by four elements, namely core values, pillars, and accelerators, processes, and outcomes. Learning health systems embody certain core values, including an emphasis on equity, participatory leadership, inclusiveness, scientific rigor, and person-centeredness. These core values relate to the SHA's values and philosophy of care. The learning health system pillars are the infrastructure and resources supporting the learning health system, whereas accelerators are those specific structures that enable more rapid learning and improvement. For learning health systems to create value, each infrastructure must not only exist within the ecosystem, but also be connected and aligned within the learning health system's strategic goals. These pillars support the execution, routinization, and acceleration of learning cycles. As depicted in the previous slides, learning cycles contain three core processes, including converting data to knowledge, which requires knowledge management, skill sets, applying knowledge to influence performance, which requires change management skill sets, and documenting changes in performance to generate new data, which requires data management skill sets. These are all the fundamental processes of learning health systems. And then the main outcome sought by executing learning cycles is the creation of value, which Minier and his colleagues define as the striking of a more optimal balance of impacts on patient and provider experience, population health, and health system costs. So I'd like to elaborate more on the concept of communities of interest or learning communities in the Miniers framework. So the execution of learning cycles is driven by these communities of interest or learning communities, which comprise the core group of actors motivated to tackle a collective problem and align learning health system pillars to achieve their goals. A critical task for communities of interest is to achieve an accepted definition of value and track its improvement. The roles that communities of interest can take may include building a shared purpose and approach to working together, establishing robust processes for identifying, clarifying, and eventually revisiting the specific problems that their members wish to address, considering the interdependencies between members and the big picture problems that require long-term solutions, protecting time for group-based self-reflection where current practices, assumptions, and solutions can be critically examined, working together via shared design, decision-making to outline alternative courses of action, weigh their pros and cons, and make fair decisions given members' preferences and priorities, taking actions and learning from doing, and monitoring impacts of these actions and reflect upon. So some core competencies that members of learning communities need to have may include system science, data science, research methods for real-world contexts, implementation science, participatory research, and quality improvement approaches, among many other competencies that might be required. So having individuals that can master several of these competencies at once and work as embedded researchers or knowledge brokers should also accelerate learning in a learning health system. So before I shift to the examples in action, I'll stop here to see if there's any questions. And I see the chat. No questions so far. So maybe I'll pause for a couple of seconds and then I'll go to the learning health systems examples in an action. So a question from Leland. Is the SHA at a place to review projects that could implement and follow the learning health system approach? That's a really good question, Leland. I appreciate that. So yes, let's see the examples in the Saskatchewan context. But to answer your question, I would probably say it depends on which project or types of projects we are talking about. Depending on the scale, the scope of the project, there are definitely resources available within the SHA that can support those projects being implemented as learning health systems projects. But for some large projects which require more resources, there might be definitely some deficiency for sure. But thank you for the question, Leland. All right, so I'll continue, but please feel free to put your questions in the chat. So one example in action is the COVID-19 Evidence Support Team, or the CEST in Saskatchewan. The CEST was a provincial initiative founded at the request of the SHA's Emergency Operations Center and combined the support of policymakers, researchers, and clinical practitioners to initiate a new learning health system in response to the pandemic. The CEST had three key objectives. One was the rapid production of the best evidence for facilitating COVID-related decision-making. The second one was to establish the establishment of a single electronic platform for systematic sharing of the updated COVID-19 reviews. And the third one was the initiation of a learning health system by constant exchange between reliable evidence, policy, and practice. To achieve these objectives, four provincial organizations, including the SHA, University of Saskatchewan, the Health Quality Council, and the Ministry of Health, partnered to establish a single data-driven system. This partnership led to the production of high quality and timely evidence reviews on COVID-19 that were used by system leaders as the starting point of a pandemic learning health system. The CEST has been a combination of success and challenges. Many of early challenges in building the CEST were related to mobilizing diverse groups of partners. Although the various partners of CEST had pre-existing relationships, they had been working independently in a way that precluded the creation of a functional learning health system. While the urgency and the scale of the pandemic was the incentive to bring these partners together, the CEST served as a catalyst to begin to eliminate silos and move towards collaborative rapid learning. Another example of a learning health system activity within the clinical excellence portfolio is the Stewardship and Clinical Appropriateness Department's knowledge translation rounds, or the KT rounds. These monthly meetings are aimed at sharing educational materials and resources in various fields, including implementation science, quality improvement, design thinking, biostatistics, clinical management, and more. Attendees receive an article for discussion about 2 weeks prior to the round. One member will provide an overview of the article, and then the attendees participate in group discussion. Since the attendees have various backgrounds and role, multiple perspectives are shared. I'd like to emphasize that both internal and external research feed learning cycles. On the right-hand side of the slide, you see a visual from the Agency for Health Research and Quality, or ARC, in which internal data and experience are systematically integrated with external evidence. In other words, research is embedded into learning health systems. So that's one of kind of the main principles or building blocks of learning health systems. Here are 3 resources out of many, many other resources to learn about learning health systems. The Learning Health Systems Journal is an international open access peer-reviewed journal published in collaboration with the University of Michigan. The Learning Health System Journal aims to advance the interdisciplinary area of learning health systems by promoting research, scholarship, and dialogue focused on theory, complex issues, conceptual syntheses, educational models, solution designs, and system evaluations designed to achieve a continuous rapid improvement in health and healthcare, and to transfer organizational practice. The editor-in-chief of the journal is Dr. Friedman. Another great resource is the learninghealthcareproject.org website. The project is run by the Institute of Health and Society, Newcastle University, and is funded by the Health Foundation. Dr. Tom Foley is the principal investigator of the project. So Dr. Foley is also have a version of Learning Health Systems framework. Because of the time, I didn't go and didn't explain that framework, but it's based in the UK, and it is one of famous learning health systems frameworks. So if you're interested, please check out the Learning Healthcare Project website. They have really good resources on their website. And then the last one, but not the least, the Learning Health Community is the great resource to learn more about learning health systems. In particular, check out the Learning Health System Toolkit on the learninghealth.org website. These are the top 3 resources I go and check out on a regular basis to learn more about this concept. And again, this is just the overview of learning health systems. There are many, many things to learn about with regard to this field. It becomes a field of science right now. There are, as far as I know, there is one dedicated learning health systems department for the purpose of training students in this field in the States, but there are some programs and certificates programs in different parts of the world for these purposes. In the Canadian context, I would say there are great resources at the University of Toronto, as well as the Women's College Hospital website that you can go and check out. Great webinars available there. The BC support unit is also doing great work in terms of advocating or expanding knowledge about learning health systems. And as you could see, SHA is also getting on board on expanding the knowledge or awareness about learning health systems and being an example of learning health systems in the Canadian context. But there are, again, many examples from Newfoundland, Nova Scotia, Quebec, many places in Canada that if you just Google, you can find great examples. So these are some of the references I used during my presentation, and hopefully they are of use for you. And I'll hand it over to Dr. Vanstone for making the case for antimicrobial stewardship program.
Thank you, Amir. That was a great overview of learning health systems. So I don't want to take too long. I just want a few minutes to kind of tie some of this into antimicrobial stewardship. And for me, where it's interesting, I mean, I only learned about the concept of the learning health system at the same time that Amir started with our group, basically. So I had a couple of meetings with him to chat about this. And I remember it really struck me how the concept of the learning health system applies to even just antimicrobial stewardship as an antimicrobial stewardship program or the work that we do in this world. And so I think that learning health system, the whole concept is important. And it's something that I think we need to really take seriously in the SHA so that we can grow that beyond, you know, kind of some of the things like Amir showed, where we've got snippets of things that are, you know, based on a learning health system concept. But we want to build that so it's an organization-wide. And I think that's important because, you know, in healthcare, we expect clinicians to practice evidence-based medicine. And I think we need, you know, to me, a learning health system is the system version of evidence-based practice. How do you do things properly from the high system level right down to a local level? And so I think we need to hold ourselves accountable to that. You know, as administrators in the system or those people working in quality improvement in the system, we need to hold ourselves accountable to that. We want to do evidence-based practice, and that means gathering that data so that when we're making policies, when we're making, you know, organizational decisions, those are based on best practice and based on evidence so that we're rolling things out appropriately in the system. So if you wouldn't mind, Amir, just running back to the what's unique about learning health systems, or I think slide 7 or so. I just wanted to highlight a couple examples of things. Yeah, that one. So just for people who, you know, are having trouble wrapping, because sometimes you look at these things and it's like, I don't know, it's a bunch of words, what does that mean? So I like to think of this in terms of some of the examples of things that we have done in antimicrobial stewardship to highlight where we're using this concept of a learning health system. So I'll use those examples specifically. I recognize we've got maybe a broader group. So as I'm talking, you can think about maybe how some of these things might apply to work in your area specifically. But so when I think about learning health systems, one of the things that we've done recently in Regina, and I know I saw Kat, I think Catherine Neal is on the call or was on the call earlier. She's been doing some of this work in Lloydminster as well. So thinking about the problem of extended length of therapy for treating community-acquired pneumonia. So this is something that we see all over the place where people are prescribed too long for treating community-acquired pneumonia in patients. And so if you follow this circle around, so looking down at the green at the bottom, starting down there, capturing your practice data. So this is something that we've done in Regina. Kat took on that role in Lloydminster to look at how long are prescribers prescribing antibiotics for community-acquired pneumonia. And then you go through the blue phase, the discovery phase, so you assemble your data, you analyze that, and you're like, oh, look, it looks like on average we're providing, 7 or 10 days of antimicrobial therapy for these patients. The yellow arrow there, so that external evidence, well, we have guidelines and information that says, well, we only need to prescribe this for 5 days and maybe even 3 days in some cases. So now you've got that, that ammunition, if you will, to go back to the providers, the care providers, and start making some changes. So this is where we get into that implementation phase. And so implementation, Amir and I could do a whole talk or a series of talks. In fact, we are doing a series of talks on that within our group about what is implementation and how that works. But the idea here is you take that data, you use it to make your intervention, or you can work off of that data to make your intervention. So in the case of extended treatments for community-acquired pneumonia, it might be things like providing education. So maybe it's that prescribers don't know that they could provide antibiotics for only 5 days or shorter. It's about, maybe using that data for audit and feedback. So maybe providers just don't know how often they prescribe longer than they should. And so if you can show them that data, it helps them to understand their practice and find those areas for improvement. And then that's where the take action piece. So then we go from seeing and knowing to the behavior change and taking action. But then the cycle doesn't stop there, right? We continue collecting that data. Did we make a change? You collect the data, you analyze it, you do your PDFAs just like you do in any quality improvement work, and you see where can we improve now? Have we reduced our length of therapy? Have there been any unintended effects? Where do we improve next? So I hope that gives people just a way to kind of wrap their head around, like, what does that mean, to have this cycle? So what is your health problem of interest? And, think about that in your mind. What is the data to capture? What is the analysis piece? And how do we implement and learn from that and keep going? And that's just one example. And I'm sure there are people all over the province doing other, types of interventions in antimicrobial stewardship, but that was just one that popped into my mind. The next piece, if you go to the next slide then, please, Amir, the concurrent learning cycles. Yeah. So I really like this diagram here because I think it really does highlight that all of this can happen system level down to local level at the same time. So, and never more true than in antimicrobial stewardship. So with antimicrobial stewardship, there are some system level interventions that you can do, but there is also a need for those local level interventions. So things that might be a priority at the system level might not be as relevant at individual locations, and individual locations around the province might differ in what their immediate needs are. So for example, if community-acquired pneumonia treatment is a problem in Lloyd and they want to deal with that, it might not be in Prince Albert or in Saskatoon, or maybe it's urinary tract infections that are the big problem in Yorkton, and so that's what they want to focus on. So you can use your data, you can look at who's interested, who are your champions that are going to help promote that work, and that's how you can decide on some of those local level interventions. But all of those can still happen at the same time that at a provincial level we're looking at interventions. And that could be things like, what did I write down here? Restriction policies, as an example. I have my own thoughts about restriction policies, but they can work. And so, you can have restriction policies that prevent people from using certain antibiotics without ID, infectious disease approval and things like that. And those can be rolled out at a system level to help prevent some of the base unnecessary use of particular antibiotics that we want to save because they are, new and useful and still work on things. So yeah, I really like this example of, and I think when I first started in antimicrobial stewardship, I was looking at that big picture and I was like, oh my gosh, how are we ever going to solve this problem? There's so many things you could tackle across the province. And so understanding that it doesn't all have to happen provincially, and not everything that happens provincially is going to make an impact at a local level, right? So there's multiple pieces within that, and they can all happen at the same time with, of course, the right resourcing. And then the last one I want to talk about, if you go to the communities of interest, slide 10, I think there, Amir. Yeah. So you said something here that resonates with me, and it's about this interdependence between members. And so whenever we present about antimicrobial stewardship to the public and even to healthcare providers, one of the things that I highlight is that antimicrobial stewardship programs, those that are really well functioning, are multidisciplinary teams, which means you've got people with different backgrounds, different specialties, different experience, and they bring those skills to the team so that together as a group, you can work better to achieve the results. And so this piece about interdependence between team members is key, because you start to form, you know, a tripod where if you lose one of the legs, all of a sudden the whole thing crumples because you've lost that expertise or that knowledge that that person brings to the team. So when we're building antimicrobial stewardship programs and committees and things like that in the province, in different areas, it's important to keep that in mind, that this shouldn't just be run off the back of, you know, a pharmacist and a physician, because if those people don't have experience in understanding data and data analysis, then you're going to fall short in that aspect of it. So it's important to bring those people on board. If all of those folks don't have an understanding of how to implement changes, then you need to bring that expertise into the group, so that when you get to the point of, okay, we've got data, the question becomes, well, now what do we do with it? I don't know how to make those changes. So it's important to have that multidisciplinary team, and that includes patient partners too. And I know that's something we want to continue to grow in Regina and make sure we're getting more patient partner involvement just in our program in general, and with some of the specific projects we do. But yeah, so understanding that interdependence, and this isn't something that can be done well by one or two people expecting them to try and do everything. That is really something that a multidisciplinary team needs to account for. I think I can get off my soapbox now, so thank you, Amir. You can, actually, we can probably just stop the slideshow. I will stop recording.